Okay, so thank you for joining. This is very informal because I'm kicking off a Edge 2.0. And the Edge tool was developed back in after the practice paper was published in 2012. And I think it took me about 5 years to get it like copyrighted and out there and distributing it. Since that time, dietitians, therapists some doctors have been using this. And what has happened is people have even reached out to see if they can translate it into Spanish, it's actually translated into Hebrew as well as Mandarin. So people have been using this form, and I felt compelled. I'm hitting my 40th year as a registered dietitian. So I thought, what can I do to try to give back? And when you're setting your goals and stuff, a lot of times you think about like your legacy and like, what do you want to leave and what do you want to do that's going to make an impact in the world? And so for me, I was thinking, okay, I've had this tool. It's a good tool. How can we make it a little bit better? And how could I get it in more hands? I know I mentioned in the newsletter that just the rate of eating disorders has skyrocketed since COVID, and there's a lot of people accessing care online. There's populations who didn't have access to care now having access to care because it's virtual. And so I wanted to figure out how can I make this more effective. And what I'd like to do is take a series of 4 weeks when we can get these links figured out and have different people come in and use share their experiences and how they work with it. So at the end of today, I'm going to give you a little case study of someone that I'm seeing right now. And it just shows me how this is so effective when you're actually past the emergency stage and you're into the phase 2 and 3 of treatment. You can actually see what you should be working on with the patient. So the longer you're a dietitian, you might realize that following your passion is really sort of what keeps you going and keeps you excited. And so like having that bigger picture and a purpose to give back to the field, that's what's motivated me to just sort of reinvent this. I have a digital format. I'm wondering if that's a value to people. If it is a value, do I need 0, 1, 2, 3? I did send a survey out, and from that survey, I got some feedback. And I'll hopefully, when I get a few more responses, I have about 11 responses, I'll be able to share those results. So this is the only instruction that I give, and it takes about 5 minutes. I personally use it when I'm in the first session, and I like to actually have the paper copy, and I try to give it to them ahead of time in their waiting room. Let's say they're ready to join, and then I would take it from them and I would go review it. And so as I would review the tool, I'm making notes specifically of certain things, like if they, and then one of the things that I do in session is I do take a pulse. And this is something that would be very difficult in a virtual setting. So I'm trying to figure out, like right now I've taught parents how to take pulses, but I'm using a lot of the syncope and the dizziness upon standing from a seated position as an indicator that potentially the low pulse, low blood pressure is triggering from the malnutrition. And other things that I would gather on this tool is that when people would explain that they are having constipation, I ask them, what's the frequency? And then I would also explore if it has changed over the last month, because is this more of an acute malnourishment, or has this been going on for a long time? And I use constipation. I use it, I call it 4 C's: cold, crabby, constipation, and lack of concentration are the things that I use to basically take from this information and right in session, right in the moment of the assessment, empower them to understand the malnourishment has actually impacted the functioning of their body, and their body doesn't have enough energy to run essential systems. Of course, we have delayed menarche and no menstruation by the age of 14, or no menstrual cycle at all. Abnormal menstrual cycles, that's a female thing. I don't know if I should put it in a different spot. I don't know if, what if they have no menstrual cycle for 2 months? Is it important to note that? And I'm just wondering how to explore that a little bit more. Weight at menarche is actually a pretty good piece of information. I know people take their own weight histories, but I think that's really, sometimes it's a good tool, especially for the adolescents. When you start getting down here in the concentration, memory loss, can't sleep at night. The can't sleep at night could be waking up at night. A lot of people who are, at least the athletes, they wake up at night and they're hungry and they can't sleep. And the anxiety and the depression and the obsessiveness always shows up with malnutrition. However, it also can show up with anxiety or depression. And do we need more questions on over concern with weight or shape? And that would help us, although we don't diagnose anorexia. And I premise, and I talked to Julie, actually, Julie just joined, and I talked to her yesterday, and she, she's been using this tool a long time, and I appreciate that she even promotes the tool. But what I wonder is it too long? What else do we need to put in here? Are there things that are in here that are never checked? And then is it hard to do the scoring? And what does the scoring mean? Like she mentioned, like a 40 to a 50 score may be more alarming. Personally, I know that the amount of the score may actually be impacted by more comorbidities along with the medical kind of risk. I remember, and I'm digging up this data, but I had an electronic medical record version of this for a year, and I saw about 50 patients, and I used it, and I tested at baseline, 3 months, 6 months, at the end of the year. And I saw, I think the number was 68% reduction of symptoms. And that was in the first 3 months. So I saw, and again, I'm quoting it by memory, but I have the data and I just got to access it and look at the numbers. But is anybody else keeping data? Is anybody else tracking what's happening? I love this one, eating food in an order. If you eat food in a certain order, that is very exposing to potential obsessive compulsive disorder. It may be actually some people, like my husband, sort of keeps his favorite bite to the last one. It's because he likes more of the flavor and the satisfaction. So it may not mean OCD, but it may be more of a hedonistic kind of desire to have, satisfaction in your eating. So we can't really speculate what all these things mean, but I'd like, and then this avoidance of specific foods, do you refer to a dislikes list or a safe or unsafe list? Are there more tools that you use? A lot of these behavioral school things, what I do at the end is I really look after they've refed for about 3 months. When we retest, a lot of these behavioral scores are still lingering around. And just to give an example, I'll wait for my case study, but this active and restless and standing when most people would sit. How many of you have walked out to accept your new patient and they're standing in the waiting room versus sitting? And, this is reflective of the leptin that drops during malnutrition. And then this piece here, family medical history, I really want to take some time to review for people who are new to this tool, how to use it to help reduce blame for parents who are coming in overwhelmed by their child's maybe eating disorder if they've accepted it, or malnutrition or weight loss, and normalize to the parent that genetics is a factor and influences why people get eating disorders. It's not the only reason, but it's not their fault, and take that time to empower them to be part of the solution, especially with adolescents with eating disorders. This one has been a big issue here, the obesity. Granted, I from a medical diagnostic kind of place, people recognize this. I recognize it would be better suited to put weight cycling under that. And I'm open to any other suggestions as far as like things to add from medical history. I do tell people that people who have family history of anxiety, mood disorders, and other eating disorders have a higher vulnerability for getting an eating disorder. And then also what I've learned from my training is that substance use is oftentimes a way to manage the anxiety or depression. And that is also kind of tied in with the mood disorder potentially, or it's its own kind of related thing. And of course, we know the genetics with that too. So I'm going to stop here and just open it up for some discussion before I share the case study. And again, if you used it, what do you like about it? What would you like to see changed? And any other things, practical things that you're wondering about. And I'm going to take some notes. So Julie, do you want to just start briefly, because you've used it probably the most?
I will. And I have my intern with me too. This is Lauren, but
good job. Bring those new future dietitians into the fold.
Yes. So but I yes. So, and as you're even going over this in detail, I'm thinking, of course there are different things that could be added, but I really think this tool is so great at just pulling things out. And if someone checks something off, you're going to ask more questions about that, right? So one of the things that I just love about this tool is everything's on one page, and I can look at one page and see, all of the things that come out. Now, are there other things that might come up? Yeah, sure. But these things really give us concrete things to work on in nutrition counseling, and also concrete things to report to the doctor or the therapist as far as, hey, this is what, they're saying they're struggling with. And so I've used it a lot. There are some clients I don't use it for because sometimes I feel like it gives them ideas. So I if I feel like it's somebody newer, I might wait a few sessions and then decide, oh, I don't need it. Or I might say, this would be useful. They already know all this stuff and it's not going to harm them to give them the form. But, and occasionally I give it to someone and they check off very few things. So, to me, that's helpful to know, like, oh, there's not a lot here. As Melanie already mentioned that, I've had some when I see the number add up to like the 40s or 50s, to me, that's a concern that there's a lot going on, that because I'm in the outpatient setting, I may or may not be able to support that person adequately. And so I will follow it very carefully and make sure that I do a 3-month follow-up. But as Melanie was saying, there is a significant reduction usually in those first few months. And so a lot of times I'll see the next score is in like the 20s. And so I think, okay, we're doing fine. We're making significant progress in the outpatient setting. And then again, checking it again at 6 months. And if it's somewhere between 10 and 20, I know we're still making progress. It is usually those last 10 to 15 points, I guess you could say. And they're usually mostly behavioral. That, we're really working on, or there's sometimes a couple of lingering medical things if it was something more serious like the period, or, something that takes a little bit longer to resolve. But really it's been very useful. And as far as the word obesity, I'm one that doesn't mind using that word. I think it's a medically appropriate word because it has a medical definition. Right. But I do know a lot of people, especially in the eating disorder treatment world, don't want to hand something to a client that has that word on it.
Right.
So weight cycling is a good idea, or even just, weight issues, or, I don't know how else you would term that, but
Chronic dieting. I mean, I just
yeah,
didn't know what else.
you could use that. I mean, even maybe just saying binge eating disorder and separating that one out. I don't know, or binge eating, because oftentimes true medical obesity is associated with binge eating, right?
True.
So that's something that,
Okay.
could go there.
Okay.
But I do think, that, most things on this list are going to really, cover, everything, that, and then when you look at the behavioral things, you can kind of piece them together as far as, oh, this looks like more restrictive eating, or, oh, this looks like more binge purge behavior, or, oh, this looks like more ARFID type behavior or orthorexic type behavior. So again, it's really useful to just have everything kind of on one page, or sometimes you just get stuff that's the whole page and then you have to kind of
Right.
take it one step at a time.
Right.
You were mentioning, Melanie, that you check pulse. I tend to not check pulse, but I think that's interesting because I tend to just not touch my clients hardly at all.
Right.
But I also, and they can check their own pulse, I guess, too, or even it would be interesting, I guess, a lot of people wear the watches. And so to just say like, hey, what does your watch reading say your heart rate is right now?
There you
So
go.
that's a way to use that I could use that a little better. But I tend to, like, if they're reporting that dizziness symptom, especially, or if they report like they feel like their heart is racing sometimes, or I just say they need to go to the doctor as soon as possible. And I also tell them that if they have like an episode where they feel like it's intense, or they're having chest pain, or they pass out, that they need to go straight to the ER. So, and I tell them, I'm like, I'm not trying to be an alarmist, but that's a sign that like we've hit a serious point. So I tend to feel like I'm not sure what I'm going to do with the information if I check their pulse, or I know some people check blood pressure too, because I feel like if it's off, I'm just sending them to the doctor. But I guess you would send them into the ER if it was bad enough.
Right. I mean, I've had 42 many times in my office, and then I basically do the therapeutic bind to create immediate action and alarm, but compassion, and say, right now, it validates the exercise kind of limiting, like right now, until your doctor clears you and we have your pulse in a more safe zone, you cannot exercise. And I say, right now, I would recommend you get an EKG today or tomorrow. One mother, I told her to go home, pack her bags, go to the ER and expect to be admitted. And she was admitted. So I told one mother that I think she, tell her boss that she has going to need FMLA, and that, this is probably, it's going to be a couple months for her. So, it's like, because they were, a lot of times patient would come from doctor to doctor to doctor, looking at this, and no one's looking at the nutrition. No one's putting it in context of the weight loss. And they just are trying to figure out, well, what's wrong? I don't know. She has stomach ache. She's been, she's not eating, Okay. So, you get a lot when you get the pulse, because it's the bradycardia is one of the body's adaptive response to not getting enough food. So the digestion slows down, the heart rate slows down, like your mind is not as clear, your brain is impacted, your bones are impacted. You can't see the bone or talk about the bone too much, but like with the runners, I do talk about the bone. So,
well, and I recommend the bone density scan too. So, and when I know that there's a trouble with orthostatics, I want that bone scan a little bit sooner, just because it's a signal that restrictive eating has been going on long enough to affect the heart, which means it's probably affecting the bone too.
Right. So good. Well, you used it a lot, and I love how you say, this looks like ARFID, this looks like, and maybe that's the kind of, that's from clinical experience, but would it be helpful to provide like a little bit more descriptors, or a little bit more,
or maybe just on kind of the clinician guide,
right?
Having like little letters next to each one that's like, you know, AN or A
Right.
for ARFID or BN or BED or something like that, where it would, you know, you could pull that out. Because you're right, that is from just clinical experience and recognizing those symptoms. And I wouldn't necessarily separate them out for the client. I think it's good that it's just all together,
Yeah.
because the
Yeah.
client, you know, can kind of pick through different things, but maybe on the clinician side to have, you know, what does that mean in terms of that? So, and that just comes from, honestly, my favorite tool to cross-reference for signs and symptoms is an old paper from like 2011, I think, that the Academy of Nutrition and Dietetics put out about eating disorders, and it lists like a ton of signs and symptoms. And so having something like that to cross-reference, but if you had, you know, just a little clinician key
Yeah.
to kind
Yeah.
of what they might signify, that could be helpful too.
Okay. Okay. That's good. I do have today, if you go to my website, you can go to the store, and the psychoeducation, if you put it in as Edge 40, if that doesn't work, then it's 40 Edge. If for the coupon code, you'll get the download of the psychoeducation. Because my Edge link is broken, but I put it in this piece, and then there's like a one pager on the psychoeducation of how to educate because you're seeing certain symptoms. So that's how I want to tie this together, is I want to be able to help dietitians, especially the newer ones, to take it and then learn how to talk about it in a session. Specifically, you know, if they're new and they're just getting started, and there's a lot of people that are maybe have clients, they don't know, you know, how to do that. Okay, let me tell you my quick, I'll do this case study. Is there anybody else that has any, Michelle, are you new, or have you used the tool?
I've used the tool a bit, and I am IADEP certified, so I'm very used to working with eating disorders.
Great. Okay.
Yeah.
Do you have any feedback? Do you have any suggestions? Do you have any thoughts?
You know, I think I've just found it extremely helpful. And like Julie was saying, I think it encompasses all the different types of eating disorder experiences, where I don't necessarily see anything missing. That I've had, you know, oh, a client has a pretty clear experience with something that this doesn't touch on at all. I found it to be pretty comprehensive and useful, and to be able to parse out for clients if they're really not having insight to what's going on. This kind of puts it in black and white, and not always, you know, clicks for them, but can really help to build the case of them needing more support, or where to go with treatment. So I found it really useful.
Okay, great. Just keep me in mind if you have any thoughts. You feel free to email or reach out. Do you have people check the boxes and then write the score, or do you usually just use the score? And how do you feel like is this confusing, having the box and the line, or?
I don't think it's been confusing. I would say people usually will check the box and then put the number with the ones that have a number next to them.
Yeah. Okay. Eileen, have you used it much?
Yes, the only time that I have used it has been because I work for a Center for Eating Disorder, and they have a very long form that we have to complete. The only time I have used it is if the client comes late, or they have been held up in therapy. So I find that I can get a lot of information very quickly using this tool. But in my case, because I am seeing most of my clients online, I am the one that is filling it up.
Yeah.
Completing it. The other thing is that because my clients come from PHP and IOP, or are actually in those programs, I always ask whether they have any suicidal ideation, or if there has been any self-harm. Because if that's the case, then they have to go to the therapist or medical provider as soon as possible.
That's a very important point. I've tried to make it not so how do I say it? Putting the dietitian in a position that they have to manage this when maybe they don't have any training, or they're in an outpatient setting.
Well,
So what are your thoughts about this?
in my setting, my role is to identify it and then just report. I don't have to do anything with that. We're not trained for it.
Okay.
So it's a very limited role, but it's a very important one.
Okay.
And the other thing is that, again, the comment on obesity, I never mention obesity at all. I just ask, if there anybody in your family that is in a larger body or have struggled with weight. That's how I present it.
Okay, very nice. But even the struggle, but that frames pretty much all of America's kind of reaction to.
Yeah, I think what you said to use the weight cycling, I think will be really appropriate to use.
Okay.
And I never thought of that.
Okay. Okay, good. Well, let me, if there's not anything else, I'm going to end with a case study, and